that I am Susan Lust, Director of the Parkinson's Wellness Project. Hi, Debbie Shapiro. It's great to see you. Okay, good, wonderful. I love seeing all my old friends. Um, we love bringing new information and great things for people with Parkinson's to do to help themselves to live well. Our website is the parkinsonswellnessproject.org. We have a lot of new things coming up, and this is a new program that we started because we heard that you wanted an hour program, and we decided to talk to the doctors and let them suggest to us their subjects that they prefer to talk about. So we called it PWPMD Lunch with Your Doctor. So of course, we're virtual, and how are we going to have lunch together? A good friend of mine introduced me to a wonderful woman named Taryn Colin, who you'll meet today. She is from South Africa, and so for every lunch with your doctor, we were going to have a little appetizer, um, and Taryn will open that up for you. We have 3 more of these in November, and we'll continue them with if you're all interested through the new year as well. I just want to make sure that everybody knows today that we'll be able to have Q&A after both speakers present to us, and that just keep your questions to the subject that we're on today. And just know that your physician, any questions you have that are specific to you, you need to speak with your physician. So today I would like to introduce Dr. Toni DiMarcaida. I was very fortunate to meet her and had a wonderful first meeting experience hearing her speak. And she chose to talk about the neuropsychiatry of Parkinson's. I'd like to tell you a little bit about her. Dr. Toni DiMarcaida is the medical director of the Chase Family Movement Disorder Center of Hartford Healthcare here in Connecticut and the associate clinical professor of neurology. Under her leadership, the Chase Family Movement Disorder Center has grown from a single center, single doctor practice in Vernon, Connecticut in November 2015, and it is now a comprehensive, fully integrated program that exists in 6 locations all across the state of Connecticut with a team of 10 highly regarded movement disorder specialists. I think that's an amazing accomplishment. And I only hear great things about your health system. And I have had an experience with one of your wonderful doctors who joined us for our support group, Dr. Maiden, and he was just terrific. Dr. DiMarcaida also completed a 2-year fellowship in experimental therapeutics and movement disorders at the University of Rochester under the mentorship of Doctors Ira Scholzen and Carl Kierbutz. You're going to have to help me with that name. A 1-year NIH-funded fellowship in experimental therapeutics and neuroaids. She did her neurology residence at the University of Connecticut and her medicine internship at New York Medical College. Dr. DiMarcaida has been the principal investigator for over 40 clinical trials for Parkinson's disease and other movement disorders and has authored numerous publications. She's also the program director of the Movement Disorders Fellowship Program at the University of Connecticut and Hartford Healthcare. She's encouraging a future generation of young physicians who we need desperately in this field to help our friends with Parkinson's. But first, as in all of our lunch with our docs, we will have a tasty appetizer with Dr. Taryn Colin. Taryn shows people that there are better ways of eating, resulting in people being less depressed, overweight,
Join
tired.
the meeting.
Thank you for keeping your sound off. Her own personal experience of transforming her health motivated her to establish the Transformational Clinic in 1998. Taryn looks at a person as a whole being and not as a series of symptoms that have to be treated. She focuses on nutrition, good eating practices, exercise, and mental health. She's based in Fairland, South Africa, which is 6 hours ahead of us. She's had a full day already, and she is a functional health coach. So please welcome Taryn, who will be speaking today on food and mood for the first 12 minutes of our program. Thank you, Taryn.
Thanks, Susan. Okay, so as you can see, I'm just full of color. And the reason for that is I'm also covering food, mood, color, and emotions in this talk today. And one of the things I thought about when I was putting this talk together was when we were children, when we were little kids and we were given a box of crayons, how excited we were to pick up that box of crayons and open it up and see all these incredible colors that used to come out those boxes. We didn't aim for the whites or the blacks. We actually went for all those colors, and we were really, really happy to actually get stuck in and color those pictures and give them to our teachers and give them to our parents, and the joy that it brought us and the joy that it actually gave to the people that we were giving it to. And somehow along the way, I think a lot of us have actually lost that ability to actually feel color and feel joy and put it in our lives. And when we think of color as well, it also can bring back memories. And how many times have you said to somebody, or do you remember so-and-so who wore that awful pink dress in the 1980s, or how we wore that in the 1980s? I mean, I'm a 1970s and 80s girl, so you remember all those big hairstyles and that fluorescent purple that we used to wear and all those blues and things like that. And they bring back memories, but also they bring in depression as well. So if you think of having long winters where you don't see the sun and you've got a lot of snow, think about how you often say to yourself, I wish it was spring, when all those colors were coming through. And when you saw those first buds popping out and you rushed outside and saw the snow melting and the grass showing, and how excited you got with seeing that color. So color brings in so many emotions. Another one that brings a lot of joy to me is my garden. I'm an avid gardener and vegetable gardener, and I cannot wait. We're going into spring now, thank goodness. And looking at all of those new vegetables that are coming up, the sun rising, the sun setting, all of those colors, how we feel those emotions. And one of the things I actually wanted to ask Susan to do today was to ask every one of you to wear a little bit of your favorite color on you today. But we will get to that in future talks. And as I've said to you in previous little teasers, is that if you're eating a lot of brown, yellow, and white, you're actually not eating very healthy. And I want to discuss something called bliss point. And I don't know if any of you have actually heard about bliss point, but it's actually formulated as a science almost in the food industry. And it's the exact ratio of fat to sugar to salt that keeps you coming back for more food. And this is very important. So when you open up a bag of crisps and you get to the end and you think, how the hell did I get to the end of that? I can't even remember it just went through me. It was so nice and so tasty. The food industry have worked this out. And all your fast food takeaway places, they all use bliss point, or Nestle's, I've got to be careful here, the things that aren't American, are these manufacturers that actually make up food that keeps you coming back. They also have boxes of food where the colors on them keep on appealing to you. Now, it's something that's very interesting to research, but red, orange, and yellow are used extensively in the fast food industry. You will find it in their logos, you will find it in their restaurants. And those are the colors that they've worked out psychologically that keep people hungry, that make you come back for more. And those colors equal better flavor. But unfortunately, those also make you very depressed. They make you anxious with the amount of additives, colorants, and things in them. But they still keep you coming back for more. And that's the sad part, is ultimately at the end of the day, the food industry doesn't really care about your health. They only care about making that sale. And so I want to change it. I've been trying to change it with my clients, is to put more color in their diet. Another thing is when you do become sick, or you develop an autoimmune disease, or you're going through a hard time and you're feeling depressed, you don't see color. You don't feel color. Everything just looks the same. Everything has got that neutral sort of hue about it. And again, bringing all these colors back into your diet, bringing them back into your life. And I want you to start experimenting with these. I want you to actually feel it. And I'm going to explain how to do that today. for me, apart from music and well, dance and food and stuff like that, music is one of those that do that to me. Is that I'm a great lover of American blues and your rock. And when I hear a song that I absolutely love, I can almost feel like it's ripping out my heart. It's like and I think that I'm just going to call you Joy, and I think you've been called Tony by Susan, is that also as dancing, when you're listening to that music and you're dancing, there's nothing more passionate about it. It's just absolutely, you feel in your bliss point. So coming back to food, is that when you start introducing colors into your food, you start feeding these neurotransmitters, and a lot of these neurotransmitters like serotonin and a certain percentage of your dopamine is actually manufactured by gut bacteria in your stomach or in your digestive tract. And so putting in these antioxidants reduce inflammation, they feed your neurotransmitters, they repair your gut, they repair your, I wouldn't say they repair your cells, but they help produce healthier cells. They nourish, they nurture, and they make you feel so much better. And in fact, there's this massive study going on in Australia by Professor Felicia Jacker. I don't know if any of you have heard about her, but she runs an institute there where she studies depression and food. And she has come up with the most incredible research and papers on this topic. So if you can, her name is Felicia Jacker, and she discusses how food can actually either make you incredibly happy or it can make you incredibly depressed. And so in my clinic, what I do is I concentrate on how much more color can you put in your life every day? How much more color can you put in your food every day? And so let's talk about how we can start adding color into our food. So I'm going to challenge every one of you in this room today to, for every meal that you have, be it breakfast, be it mid-morning, be it afternoon, be it evening, how much more color can you add to your plate? Be it a little bit of lettuce, a slice of tomato, or just making a soup that's full of color, adding in herbs and chopping up parsley, chopping up a bit of coriander. How can you add color to your diet every single day? And the other thing is, I'd like you also to try and wear some of your color. Wear your favorite color this coming week. Try and pick a bunch of flowers and put them on your table. And every time you look at those flowers, just feel the joy that you feel. Watch a sunset, watch a sunrise. These all matter when it comes to eating, because if you're feeling down, you're going to turn to the brown, oranges, and whites to fulfill you. And that only makes the food industry happy. So I need you to put color into your life to actually feed that joy that I know is deep down in there. And don't get bogged down by all the I won't say all the medical stuff, because you need all of that. You need all those drugs, but don't forget that you still alive. You're still alive. Bring out those old photograph albums and start to look at all those old photograph albums and feel the joy that you felt when those photographs were taken. So I'm going to challenge every single one of you is to even take a photograph and send it to Susan that maybe she could post on her website. And I'm almost thinking of holding a competition to see who could actually send the meals with the most color on their plate. I don't know if anyone's feeling happy about this or thinking like, how am I going to do it? But I would like to see that you start repairing your body, reducing inflammation, and putting more color in. One of the ways that I use it is with my green smoothie. So I use this analogy, and I tell my clients to always think about it, because not everybody likes green. But if you can think of all your cells just lying there, they're just there. I call them just, in Afrikaans in South Africa, we call them verlep and verlam, means like they're just lying there. And if you just take a sip of that green smoothie with all those incredible colors of that green rainbow going into you, and imagine those cells opening up and taking in and absorbing all that beautiful green, all that life, all that chlorophyll that is going into it. And imagine all your cells just bouncing around.
Join the meeting.
But I loved my clients to feel joy. So every time you take a sip of food, you choose something, you put it on your plate, feel the joy of what that is doing to you. Color is healing. Food is healing. And try and get it as natural as possible. Try and stay away from your boxes, your packets, your tins, and try and just chop up a little bit of color on your plate every single day. Thank you.
That was terrific, Tara. That was great. No, I thank you very much. I hope everybody enjoyed that. That because we will have Taryn come and do a whole presentation for us on different subjects in the near future. We will have her recipes on our website. Some of them, we'll dose them out slowly to you. I just want to remind everybody that we wouldn't be here without our terrific sponsors. So I do want to thank Acadia and Kaiwo Kieran for being here with us today. So it's because they are so supportive of our groups here that they keep us going. So now, Dr. Dumarkaida, are you ready? Let's turn on your sound and we're gonna share your screen. And we're looking forward to hearing from you.
Very good. Can you see my screen?
Yes, perfect. Yes.
Very good. Yes. And to my friends who are joining us from Connecticut, I would like to introduce you to Susan Lust and her group, her wonderful group, which is the Parkinson's Wellness Project coming from Pomona, New York. So what are we, not meggers? Meet the New Yorkers. Yes. But thank you everyone for joining us. And Taryn, that was fantastic. And it segues beautifully into the talk that I'm giving today, which is the neuropsychiatric aspects of Parkinson's disease, a lot of which has got to do with mood and some of the behavioral and psychological challenges that we find is something we need to address in caring for our people with Parkinson's. So some of my folks from Connecticut would have seen this talk, but what I found is that a lot of times just hearing the same talk a couple of times, you always learn something new. So I hope that this is going to be true for you as well. One of the things that we have recognized as researchers in the field of Parkinson's disease is that when we talk about slowness of movement, rigidity of the muscles, the tremor that we associate with Parkinson's, that's actually just the tip of the iceberg. And Parkinson's disease is so much more complex. And there are so many other systems of our body that are involved in the phenomenology of Parkinson's disease. In fact, these non-motor symptoms, which refers to everything else but the physical symptoms of Parkinson's, is reported by 99%. Almost every person with Parkinson's is going to say that they have at least one, if not more, non-motor symptoms that can be more debilitating to them and can impair their quality of life so much more than the motor symptoms. In fact, just very quickly, I can easily call to mind many people who have told me, my tremor is under control. I'm doing things pretty well, but it's the constipation. My gosh, if you can just fix the constipation, I will be a happy camper. And there you go again, Taryn, with your healthy eating, the food choices that we make. It doesn't have to be a pill. We have to live healthy lifestyles because so many of these non-motor symptoms can be addressed by the choices that we make for ourselves for our everyday lives. Cognitive impairment is one of the more common non-motor complications of Parkinson's disease, and I will tell you significantly more about that in a little bit. And again, when we start talking about the neuropsychiatric aspects, the caregiver burden on the basis of these neuropsychiatric symptoms can be so much more than the caregiver burden from a resting tremor. So, the most common neuropsychiatric symptoms in Parkinson's disease are cognitive impairment or dementia, apathy, which I will define in a little bit, depression or anxiety, and PD psychosis, hallucinations and delusions. I particularly like talking about hallucinations and delusions because I want to destigmatize this in our community, for people not to be afraid to tell their physician that yes, they are seeing bugs on the wall. Yes, there seems to be a little girl in the corner of the room, and not be afraid to say so because it can be addressed. Another distressing neuropsychiatric symptom that I want people to be aware of is impulse control disorders, because this is something that a lot of people are embarrassed to admit to, but it can be a medication side effect. And I'll tell you a little bit more about that as well. Okay, so what is apathy? Apathy is different from depression in that although it manifests as a lack of motivation, it is not actually associated with a feeling of low self worth or low self esteem. It's not associated with sadness or a loss of pleasure. It's just loss of motivation. It's an, a motivational syndrome. But for us to say that somebody actually has apathy associated with Parkinson's disease, it can't be just one day I don't feel like doing anything. You know, for it to actually be part of the phenomenon, it has to be more sustained. So if someone is apathetic for 4 weeks or more, then we recognize that it might be one of the symptoms of Parkinson's. So there is a loss of, I want to do this because I want to achieve that. And this can be present in a fifth of people with Parkinson's disease, even before they start medication. And this can occur with or without dementia, with or without depression. But certainly, when people have apathy, then there are other aspects of their management that get affected by it, because then they're not exercising, they're not doing healthy things, they're not really motivated to be aggressive in their Parkinson treatment or their Parkinson regimen. So, if you or your loved one are feeling that apathy is something that's occurring for you, making your day more regimented is key. So you have to create a structure for yourself that forces you to do things even if you don't feel like it, because you know it's good for you. And I'm going to be mommy here and say it's good for you, just do it. So create a schedule that is amenable to your lifestyle in terms of what time you want to get up. You don't all have to get up at 7 a.m. or 9 a.m. Whatever time is good for you. Start from that moment. Okay, my morning routine 10 to 10:30. I'm going to have breakfast 10:30 to 11, and then I'm going to exercise, and then I'm going to read the paper, and then I'm going to have lunch, and then I'm going to see a friend, and then I'm going to go out for a walk. But as structured as you can make your day will overcome the challenge of just not feeling motivated to do anything for that period of time. So, counseling and education is always important. And that is the role of your physician, your providers, and the team of clinicians who care for people with Parkinson's disease. There are behavioral strategies that then overcome this executive dysfunction that occurs in Parkinson's. And then, of course, there are always medications. Again, my group from Connecticut will know that I always say I have a pill for everything. So it's just a matter of whether it's worth your while and whether you think that that particular symptom is significant enough that you do want to take a pill for it. But if it is significant enough, then we use antidepressants. Even if apathy is not related to depression, we found that it might help. We use some of the dopamine agonists, the medications that we use to treat Parkinson's, like the Nupro patch, that's rotigotine, or pramipexole, which is Mirapex. Peribidil is not available in the U.S. We use the medications that are used for treating dementia, and we have found that the property of it. Remember that all of these medications that we use in neurology act in some form, in some way or another, to modify the chemicals in the brain that cause certain symptoms. So although acetylcholinesterase inhibitors such as Aricept, and I'm using brand names so that it's more easily recognizable for you, Aricept, Exelon, or that's donepezil, rivastigmine, galantamine, these are medications for dementia, but it modifies acetylcholine in the brain. So we may find that it's helpful for other symptoms, including apathy. And of course, there are stimulants that are used for attention deficit disorder in kids. Stimulants are uppers, and that can help as well with motivation. So how about depression? Very common. We're saying 25 to 40% of people with Parkinson's will develop depression, and it is not situational. So that is a myth. Some people say, well, of course I'm depressed. I was just diagnosed with Parkinson's. But that is not the case. It's all chemical based. So the reason why depression is common in Parkinson's disease is because the serotonergic dysfunction, which is part of the pathology of Parkinson's disease, causes depression. And case in point, somebody is diagnosed with terminal cancer and they know that they have 3 months to live. Their incidence of depression is less than the incidence of depression in Parkinson's disease. Because in terminal cancer, there is not the neurotransmitter involvement. They do not have a neurologic disease that causes that chemical imbalance that causes depression. For most people, depression is mild to moderate, but if it is severe and you or your loved one recognizes that you are clinically depressed, please speak to your physician or provider because it is treatable. It's under-recognized. People don't like to talk about it. Loved ones don't always mention it to their neurologist when they see their neurologist, but please do, especially with severe depression. Suicide can occur in people with Parkinson's disease. And after the wonderful lives you have lived for all these years, we certainly would not want you to succumb to depression leading to suicidal intent or ideation because of an untreated chemical imbalance. And hear me say that it is not you, it is not under your control, it is a chemical imbalance. So give your physician the opportunity to treat that chemical imbalance and prevent any untoward outcomes. So how do you know your loved one is depressed? How do you know that you are depressed? As opposed to apathy, there is a depressed mood. There is loss of interest or pleasure in things that you used to enjoy. And then there are these physical symptoms. Either you're losing weight or you're gaining weight because either you want to eat too much or you don't want to eat at all. Similarly with sleep, you either sleep too much because you're depressed or you can't sleep at all. Some people get agitated. I say to the men out there, I'm sorry to say this and stereotype you, but men, when they're depressed, they get cranky. Women, when we're depressed, we get sad. And, it's just a general observation of how people can present differently. And a man might not think he's depressed, he's just cranky. But that could be a symptom of depression. They don't want to see their family anymore. They isolate themselves. And then there's that feeling of low self-esteem and feeling of worthlessness, feeling of no future, feeling of guilt. So these are the things. If you are feeling this way, please do speak with your physician or provider. So the first step is to recognize it. And then after this, we have to have the conversation. There's psychotherapy that helps with depression, but most of all, again, recognize it's a chemical imbalance, and there are a lot of antidepressants that we can use. Some people tell me they don't like to take antidepressants because they don't want not to feel what they feel. But know that these feelings of depression are not your feelings. They're not how you need to feel. You don't need to feel this way. So even if you take these antidepressants, it will just correct those abnormal feelings. It will not take away your ability to empathize with somebody who's going through a crisis. They will not affect your ability to feel sad when it's appropriate to feel sad. It will just correct the chemical imbalance that causes clinical depression. And then, of course, the other aspect of depression is anxiety. And anxiety is treated with many of the same medications that we use to treat depression. But for people with Parkinson's disease, usually the manifestation is just social avoidance. And some people will say, well, I'm avoiding my family because I don't want them to see me so slow, or that my tremor is so prominent. But again, remember, it's more than that. It's a chemical imbalance that needs to be treated. So if you are finding that you have actually developed a social phobia, then try to see if this might actually be anxiety. And anxiety will manifest in ways that can limit your treatment for Parkinson's too, because people who have anxiety have a more than ordinary fear of medication and medication side effects. And they will manifest with physical side effects to the medication based on their anxiety. So some people will say, whatever medication I take, I just get nauseated. I just feel fuzzy headed. And it's any medication, even if the medication we know does not cause nausea. And what could be happening is that the anxiety is making you manifest with these physical side effects to any medication that is tried. So treat the anxiety with meditation, with um, uh, participating in exercise classes, doing yoga, eating healthy, bringing color to your food and your life, and see if it will help mitigate the symptom of anxiety so that you can treat the symptoms that need to be treated with medication a little bit more appropriately. So similar to that, again, I have a pill for that. So if it is to the point that you feel you need medications, there are a number of medications that can be used in addition to the healthy options that we choose for our lifestyle, and psychotherapy and cognitive behavioral therapy. So I said I particularly wanted to make sure to talk about hallucinations, to destigmatize it. So what are hallucinations? It is when people see things that are not there or believe things that are not based in reality. So for most people with Parkinson's, it's going to be a visual hallucination. So if you see something and there is really nothing there, you see people outside your window when you know that it's wintertime and there wouldn't be children playing in the yard, or you see ants on the wall, or you see worms in the food, or little rats scurrying around, and you know that you don't live in New York and your home is not rat infested. Although I don't think that happens at Pomona. My son says it's very common in the city. But if you see things that aren't there, then that's a hallucination. If you see things in lieu of something that's actually there, so now we're talking about a towel looking like a dog, or a tree looking like a bear. So that is called an illusion. It is still a form of hallucination, but it's, I guess, a little milder because you're actually just misperceiving something that's there. And then, of course, the delusions I already mentioned. It's a strongly held belief that is not based in reality. And for people with Parkinson's, the most common delusion is spousal infidelity. And this is so heartbreaking because I have many, many couples who come to me. They've been married for 64 years, 59 years. My prize winner is 76 years of marriage. And then at the point that they develop PD psychosis, they are convinced that their wife or their husband of 64 years is cheating on them with a caregiver. And nothing I can say, nothing their spouse can say will convince them otherwise because they hear them in the room. They see the person coming in and out. And sometimes the person doesn't even exist. It's not even accusing them of having an affair with somebody who's around. They're accusing them of having an affair with a hallucination. And this is so pervasive and so strongly held that no matter what the spouse says, it just erodes the marriage completely. And this is such a common delusion in Parkinson's disease that it is truly heartbreaking. So when people develop psychosis, I do think that it is absolutely important to manage and treat it immediately before it gets worse, before it gets more, before it interferes with your life and your relationships with your spouse, with your children, and with your ability to live your life unimpeded by these people who are coming to dinner every night. So recognize that hallucinations and delusions can be part of Parkinson's disease, can be a side effect of medication, can be a symptom of something like a urinary tract infection. So this is something that you absolutely have to tell your physician or provider about if you are seeing things. The mild form of psychosis is actually just a sense of presence. So sometimes, you know how you look, you feel like someone is over your shoulder and you feel like somebody's there. You don't actually see anything because it's not a hallucination. You're not hearing anything either, which would be an auditory hallucination. It's just a sense of presence. And that is a very mild form of PD psychosis. So if at any point you are experiencing this, please do speak with your clinician. They say that up to 50% of people with Parkinson's disease will develop PD psychosis, but that is primarily because we are counting sense of presence in that number. If we're only talking about visual hallucinations or delusions, then the number is more like 20%. So I already mentioned this. Medications can cause it. So if you develop hallucinations, just started a new medication, even if it's not for Parkinson's disease, it could be for your for bladder problems, for urinary frequency, or going to the bathroom too often at night, which is called nocturia. You start a medication for your bladder problems, and then you develop hallucinations. Or alcohol, recreational drugs certainly can cause hallucinations. And all of these other things that are going on medically with you. If you have problems with your vision, you might be more susceptible to developing visual hallucinations. So as with anxiety and depression, there are all of the things that we can do prior to taking medications, such as cognitive techniques, education, cognitive behavioral therapy, supportive therapy, and then we talk about medications. When we talk about medications, because I mentioned that sometimes it is the Parkinson's medication that contribute to the development of hallucinations, your physician may say, well, because you have illusions now, or you have delusions now, I have to take away your amantadine, or I have to take away your Mirapex or Pramipexole. And that could be the option that helps. However, for many people, taking away that amantadine or that pramipexole may result in worsening of their Parkinson's symptoms. And now their levodopa no longer lasts 4 hours, it only lasts 2 hours. Or taking out the amantadine might result in somebody now having more dyskinesias, which are the fidgets that can sometimes be a side effect of levodopa. So sometimes coming off the medication is not an option. And what we really need to do is take a medication again to correct the chemical imbalance that causes psychosis, that's causing these hallucinations. Remember, however, and this is something that I am very happy to be able to say to as many people in venues like this as I can, most medications for hallucinations are contraindicated in Parkinson's. And for any care partners who are listening to me right now, you have to be an advocate for your loved one if they are ever in the hospital. And because they're in the hospital post anesthesia, or because they have a urinary infection, or even dehydration because they weren't drinking enough water, drink a lot of water, everyone. So because of these things, they now have hallucinations. And while they're in the hospital, the doctor in the hospital, not understanding completely about Parkinson's, will say, oh, we need to give your husband or your wife haloperidol. Oh, we need to give them olanzapine. Remember that word, olanzapine. You do not want that. You do not want to take these anti-hallucination or anti-confusion medications that block dopamine. Dopamine is the chemical that is deficient in Parkinson's. If you take a medication that further blocks it, there's a problem. So the only medications that are allowed for psychosis in Parkinson's disease are clozapine, quetiapine, and pimavanserin. And again, I'm going to say the brand names so that you recognize them. Clozapine or Clozaril, quetiapine or Seroquel, pimavanserin or Nuplacid. Olanzapine you see in this table is not effective and has unacceptable risk for Parkinson's disease. That's Zyprexa. And there is a long list of other medications that are contraindicated in Parkinson's disease. You can get it from your physician or provider. You can get it from the American Parkinson Disease Association. You can get it from the Michael J. Fox Foundation or the Parkinson Foundation. All of these organizations that advocate for communities with Parkinson's will have this list of contraindicated medications in Parkinson's. The common denominator, they are dopamine blockers. So you do not want to take anything that blocks your dopamine further. And see from this slide that it's not just antipsychotics, it's also antiemetics, things that you take for nausea. So if you're in the hospital because you had knee surgery and you're now nauseated from the anesthesia when you're in the recovery room, they might want to give you Compazine or Reglan. These anti-nausea medications are contraindicated in Parkinson's. So you have to tell the physician, I can only have the anti-nausea medications that do not block dopamine. So long as you remember that, you don't have to remember all these names. Just tell the doctor, I cannot have any medication that blocks dopamine, whether it's an antiemetic, an antipsychotic, an antidepressant, an antihypertensive, that's for blood pressure. None of these medications that block dopamine are allowed in people with Parkinson's. So let me talk a little bit about impulse control disorders, because this is also important to recognize. So what this refers to are pathologic urges. And I emphasize the word pathologic because, of course, we all have urges. I have a strong urge right now for the blueberries that I see in Terrence's background. But, you know, when the urge becomes uncontrollable, then it's pathologic. Impulse control is lost. So People are now acting on their impulse without thought of the consequence. And these are usually what most people would consider pleasurable activities: eating, gambling, shopping, women, sexual activity, creative work, painting, um, poetry writing, building wood blocks, wood carving, collecting antiques, collecting cars, So it can be any of these activities that some people say they never even thought of doing before, never had any desire to gamble in the past. And then all of a sudden, they develop this uncontrollable urge to gamble. And the reason why it's so important to talk about this is because, as I said, it's not under your control. It's a side effect of dopaminergic medications, most commonly the dopamine agonist. So if you are noticing that you have lost a little bit of impulse control and you are developing pathologic gambling or shopping or sexual behaviors, and you are on medications such as pramipexole or Mirapex, ropinirole or Requip, rotigotine or Nupro patch, then these are the dopamine agonists that more commonly cause impulse control disorders. Not to say that any of the other dopaminergic medications can not cause it. Levodopa can cause it. Any of the dopamine medications can cause it, because these impulse control disorders are a dopaminergic effect. So anything that increases dopamine can cause impulse control disorders. It's just that more commonly we have seen it with the dopamine agonist. And the consequences can be devastating. And again, I can tell you firsthand of marriages that have broken up because of the ICDs, of people from very high level professions losing everything, losing their homes, losing their jobs because they just couldn't stop gambling. And the most heartbreaking part of this is that, at least for us who are movement disorders neurologists, almost at every visit, we're asking people, have you developed any gambling compulsions? Have you developed any shopping compulsions? And they say no. They don't want to be found out because these activities are pleasurable. They will not admit to it. So again, care partners, if you see there are too many Amazon boxes coming to the house and you feel that, there's spending that's happening, do look over your loved one's shoulder. Do monitor and regulate with the love that I know that you have for them. Ask them to be transparent with their accounts, because it could be that they are not recognizing that they have developed an impulse control disorder. Okay, so what do we do about it? If somebody has an impulse control disorder and it's related to a dopamine agonist, the first thing we have to do is stop that dopamine agonist. There is no ifs, ands, or buts about it. It has to come off. And it has to come off slowly. Again, do it with your physician or your provider, because they have to help you come off this medication. If you take away your medication too quickly, you will develop more problems like withdrawal. It's like a drug addiction withdrawal symptom. There's anxiety, there's panic, there's palpitations, there's irritability. So you cannot stop your dopamine medications cold turkey. You have to talk with your doctor. And the medication that is used to counteract opiate addiction, naltrexone, has been used to counteract impulse control disorders as well. There are some other medications that we may consider to try to help with impulse control disorders if coming off the dopamine agonist does not help. And of course, cognitive behavioral therapists with the psychologist or the social worker is also helpful to control impulse control disorders. So now we're going to talk about cognitive impairment. And I want to point out that there's a difference between when I say cognitive impairment and when I say dementia. So cognitive impairment refers to just a change in your overall abilities to do mental work. So it could be a change in your ability to do math, or a change in your ability to easily find words, or your visual perception, your spatial perception. So all of these things can be a manifestation of a change in your cognitive process. Doesn't mean that you have dementia. It just means that the Parkinson's has affected cognitive processing. Cognitive processing speed is more commonly affected in Parkinson's disease than the other symptoms of, say, Alzheimer's, which is loss of memories. So loss of memories does not occur very commonly in Parkinson's. It's more of just a slowness of processing, meaning that it might take you a little bit longer to remember that person who was in that movie that you love. Or you may not be as able to multitask as you used to be. And you know how we are. We are watching the news on television. We are making dinner for our loved ones. And at the same time, we are answering the text message on the phone because the grandchild wants to borrow your car for the weekend. So your ability to multitask like that may not be as good as it used to be. So the incidence of cognitive impairment in Parkinson's disease is about 25%, and about 40% can progress to actual dementia. But the cognitive impairment can even predate the onset of Parkinson's disease, and many people who have cognitive impairment will not progress to dementia. So as I mentioned earlier, these are the features of cognitive impairment, the cognitive domains that may be more commonly affected in Parkinson's disease. As I was saying, it's executive function. So it's more of the planning, the mental flexibility, which is multitasking. Attention may be a little bit less. So your ability to focus for longer periods of time may not be as good as it used to be. Abstract thinking. So now you're a little bit more solid in the way that you think. Visual spatial, meaning that, driving. So you have to be aware that if you are noticing that you are miscalculating the distance of that curb a little more often than you would like to, know that it could be because of visual spatial impairment in Parkinson's disease. So this is something that can affect your driving because your depth, your perception of distance may not be as good. Your perception of the whole area that you're looking at may not be so good. And then, of course, to some degree, there is an effect on memory, but mostly strategic encoding means, again, that careful planning that is part of executive function. And language is primarily preserved in Parkinson's disease, as opposed to people with Alzheimer's dementia, where language is very commonly involved or affected. So for most people who have mild cognitive impairment, it does not interfere with their everyday lives. They may be a little bit slower to retrieve certain information, but they can do things quite well. And this is an example of visual spatial deficits. So the instruction for this task is always that you're given a blank circle and you have to put the numbers of the clock, and then you have to put the hands of the clock at 10 past 11. And look at what happens in somebody who's visual spatial impairment. First, they may not be able to put the numbers where they belong. They cannot put the hands of the clock the way that it needs to be. Or they think that they have the clock hands, but they put it everywhere, or they cannot draw a clock at all. So this is what we see when somebody has significant visual constructive deficits or visual spatial impairment. The test that we use to measure cognitive impairment in Parkinson's disease is called the MoCA, Montreal Cognitive Assessment. And it is more complicated than the screening tool that we use for Alzheimer's disease. Call out to people with Parkinson's because, you know, the abilities of people with Parkinson's are preserved for more simple things such as repeating three words. People with Parkinson's, even with moderate dementia, can still do that. So we had to create, the researchers had to create a test that was a little bit more complex in order to capture the mild cognitive impairment that can occur in Parkinson's disease, because the more simple test of the mini mental status examination that we use for Alzheimer's disease may not capture the cognitive impairment in Parkinson's. So the risk factors for dementia are myriad. If somebody has REM sleep behavior, if somebody has lower baseline scores for their mental abilities, if you're noticing that they're sleeping too much, then the likelihood is that the mild cognitive impairment may progress to dementia. Lewy body disease, just very quickly so that you know the term. There are some physicians who might tell you if you have dementia or cognitive impairment with your Parkinson's disease, maybe you don't have Parkinson's, maybe you have Lewy body dementia. This is not true. To make a diagnosis of Lewy body dementia with cognitive impairment and hallucinations needs to predate the Parkinson's symptoms. So if you've already had Parkinson's for 3 years, at least more than 1 year, and now you're having cognitive impairment or hallucinations, this is not likely to be Lewy body dementia. So again, treatment, if the cognitive impairment is a side effect of medication, of course we would like to stop the medication if we can. But otherwise, we use the medications called acetylcholinesterase inhibitors, a whole mouthful. Aricept, donepezil, Exelon or rivastigmine, but only Exelon or rivastigmine is actually FDA approved for treatment of dementia and Parkinson's disease. The other medications probably have efficacy too, but they just didn't go through the process of getting FDA approval. So I tried to go through that as quickly as I can. There's a lot of information always, but I just wanted to do a call out for my team at the Chase Family Movement Disorder Center, because when we talk about neuropsychiatric symptoms in Parkinson's disease, besides the physicians that we have who are all movement disorder specialists, we have 10 movement disorder specialists now at the Chase Family Movement Disorder Center. But we are also so grateful to our APRNs and PAs, our neuropsychologists who are part of the team. We have 5 of them, and our social workers who are there to provide psychotherapy, to give you resources to support you, and to do cognitive behavioral therapy. So, as always, Susan, thank you for the opportunity to address your group. And it is always a privilege for me to have this opportunity to give more
Thank you very
information.
much.
There's always so much.
This was terrific. I'd like to ask before we end if there are any questions people would like to add, to ask now. Now is the time. We have a couple of minutes. Would anybody like to ask anything? I know Dr. DeMarcaida covered so much. It's a little overwhelming.
Yes, but you know, I
Brian?
saw a few comments in the chat box. But
Brian,
yes,
do you want to say something, Brian?
Totally. Thank you for doing this today. Sounds like someone has some awesome bird.
good friend, and he advocates for the community. So absolutely reach out and get more information.
Doctor, what is the issue with finasteride? Somebody asked that question.
Say that again.
What is the issue with finasteride? Am I saying that word right? Finasteride?
Finasteride. Yes, I am not aware that there is any issue with it. Is there anything specifically that you wanted to ask about it?
Joseph, did you want
Finasteride is,
to ask,
yeah.
Joseph, do you want to ask something about that?
So if there might be maybe a propensity for cognitive side effects with it. It's not a dopamine blocker, so it may not be an absolute contraindication. But there are certain medications with anticholinergic properties that might contribute to confusion, hallucinations, and that might be one of them.
Fatigue.
Oh, fatigue. Yes, yes. Fatigue is a common side effect of many of the medications.
Thank you.
So I want to thank everybody for today. I think it was a terrific program, Taryn and Dr. Dimarcaida. I would just like to tell everybody that we are having our first in-person event in October here in Rockland County. And we will, yeah, we're going to have, it's a concert, it's a program, and it's a wellness expo with Dance for PD and Ping Pong Parkinson. And the Davis Finney Foundation will be there. And we're going to have fantastic groups here. I hope, Dr. Dimarcaida, you will be able to join us. I want to talk to you about that afterwards. But it's outdoors. We are taking into consideration the environment of what's happening today. It's outdoors, it's fall foliage, and we're planting tulip bulbs because it's a tulip festival. It's the time to plant, and it's a free event. We're having plenty of food and drinks, and we'll keep you posted. We hope to see you all there. Taryn will have an exhibit there at the table, so you'll be able to learn more about her recipes, which will be on our website as well. So, any questions, any colors you want to send to us, we're happy to receive them and post them. Please keep up the good work, living well, and take care, everybody. Thank you both.